So, may I have your attention, distinct faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event of Neonatal Parshala series hosted by the National Neonatology Forum Gujarat chapter. The focus of today's session is neonatal seizures, a resource-based management. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahiya sir, the Honorable Secretary of NNF Gujarat chapter, to start the event today with his enlightening words and for the further coordination. So the dice is all yours, sir. Please proceed.
Thank you so much, Ritu Parna. So today we are honored to have Dr. Manish sir with us. It is a great privilege, sir. And Somsekhar sir has specially requested your lecture for this series because he had liked it a lot, and sir had praised about you so much that we had a discussion that we should have your lecture for our neonatal Pathshala series. So thank you so much, sir, for joining with us. Somsekhar sir, since Nirmal Choraya sir, our president, is not able to join today, I would request sir to say a few words and then I will introduce and then we can start the session.
Thank you, Dr. Kunal, for arranging. I'd like to thank Dr. Manish Parak for uh, accepting our offer to take a lecture on this platform. So just to give a background, Dr. Manish is a senior pediatric neurologist from Jodhpur. He'll get introduced subsequently, but just and I've known him for quite a few years now, almost maybe 7, 8 years at least, that we have interacted at various platforms. Recently, we were at an international neurocritical conference in Loni, neonatal neurocritical conference, and where I had the opportunity to listen to his lecture, and I was very much impressed in the details in which with the patient videos, etc. So I thought that this is something which is very essential that all our students should get exposed to, and I thought neonatal Pathshala was a very good platform for this particular topic, where postgraduates in pediatrics and fellowship residents in neonatology and DM residents would have a chance to listen to this. Thank you very much, sir, for accepting a request, and I hope everyone will be able to listen to it in detail and, of course, ask questions towards the end. Back to you, Dr. Kunal. Thank you very much.
Thank you so much, Somsekhar sir. So I would take this privilege of introducing Dr. Manish Parekh sir. Sir is an MD pediatric medicine. Sir has done clinical fellowship in child neurology at University of Toronto Hospital for Sick Kids, Royal College accredited program. Sir is a senior professor and former head Department of Pediatric Medicine, in charge Pediatric Neurology Services, the nodal officer at Department of Pediatric Neurology at Dr. SN Medical College, Jodhpur, Rajasthan. Sir has various research publications, more than 80. Sir has written chapters in more than 5 books, which are of international repute. Sir is a member of IPSO Executive Committee and Editorial Board. Sir is also scientific committee member of International Pediatric Stroke Organization 2024. Sir is a vice chair for GAPSR and member editorial committee also. Sir is a trainer of BPNA, Pediatric Epilepsy Training 1 to 3rd level courses. Sir is a member of International Pediatric Stroke Association and members of various other reputed associations. And so I would welcome you, sir, and request you to kindly take over and conduct the session. So thank you so much, sir.
Thank you so much, everyone. And my special thanks to Dr. Nimbalkar, President-elect NNF. And, he's a very dear friend of mine. And I think one of the pioneers in neonatology in this country. And he is a person of international repute, and I learn a lot from him. Thank you so much, Dr. Kunal, for having me here on this forum, and also NNF Gujarat. And I think, whatever this talk will deliver is just some of the most basic things. So I'm just trying to put in everything, from the most fundamental part. It's very, I believe understanding neonatal seizures is very easy. Each one of us is doing this, but the problem is that recently things have, many different fora, many different, um, organizations have now put this into a separate perspective where everything is more related to electrophysiology. Okay, and that is complicating everything. So what we'll try and do today is try and get things into the perspective of a resource-based approach. Okay, so it cannot be very interactive while I'm talking, but definitely you can all note down the questions, and then we'll take these questions later on, and I'll try my best to answer it along with other experts here, including Dr. Nimbalkar. So this is actually a talk on management of neonatal seizures, a resource-based approach. So this country is very diverse. And in India, we have, people managing neonates even in a sub-center, in a small private setting, in a small primary health center, or maybe a secondary type of setting where there's a multi-specialty, nursing home, or a place like Dr. Nimbarkar's facility or our facility, or maybe another big hospital where you have all the neonatal services. You have a neonatologist, you have a neonatal neurologist at disposal. And this you know takes there can be a resource limitation at some settings, and there can be best resources at other settings. So we'll try and put this into perspective in this particular talk. Okay, so the objectives of this talk are: number one, I'll try and give you an overview of what the epidemiology, incidence, and prevalence of neonatal seizures. Then talk about some relevant clinical definitions and the rationale to treat seizures in neonates aggressively.
थोडेसे ते थोडं बीबी पाठवलं याच्यावरचं हे खराब होतील ना ते स्ट्रॉबेरीज
Ritu, can you mute all? Ritu Parna. Yeah, thank you.
Done.
Can you hear me?
Yes, sir.
Okay, and can you see my slides?
Yes, sir, it is clear, sir.
Okay, so in this particular talk, my objectives will be to talk about the epidemiology, incidence, and prevalence of different neonatal seizures and in different populations, such as the term neonates and the preterm neonates. I'll just stop my video so that there will be a good bandwidth, and I hope that will be a much more better kind of transmission. So I've just stopped my video. Okay, so we'll also be talking about the rationale to treat seizures in neonates aggressively. The reason I say this is because whenever there is a seizure in a neonate, it's very, very complicated affair. There are many different etiologies, and then at what level and what aggressiveness should we treat is always a question. Okay, then I'll talk about the etiology and the latest classification. I'll also talk about non-epileptic movements in seizures like events in neonates. Then we'll discuss the level of evidence for the clinical and electrophysiological identification. And we'll also talk about the resource-based diagnosis and treatment. Okay, so whenever there is a seizure in a neonate, the problem is whether this is an epileptic seizure or a non-epileptic seizure. What is the neurological status of any child? How to manage it, and what is the prognosis? Okay, so let's have a look at this particular seizure event. So everyone just have a look at it, and then I'll try and put this into perspective. Okay, so this is a neonate, term neonate, was born at around 38 weeks, was born depressed, and then required NICU admission. Now, the problem is that this child is not breastfeeding well, is not having a good awake and sleep cycle, and is having these movements. Okay, so I know it's difficult to interact on Zoom platform, but everybody, including myself, is always wonder whether this is an epileptic seizure or this is an non-epileptic seizure. Okay, so मैं थोड़ा bilingual भी हूँगा, so I cannot speak Gujarati well, but definitely Hindi and English. So the problem for all of us is कि epileptic and non-epileptic. Number one. Number two, what is the neurological status? Whether this child is really encephalopathic or not. And then if this is an epileptic seizure, how do you manage it? If this is a non-epileptic seizure, how do you manage it? And what is the overall short-term prognosis and long-term prognosis? Okay, so in this particular talk, we'll try and resolve all this. Okay, so all of us know that neonatal seizures are the most common neurological emergency during the neonatal period. The incidence is almost 1 to 5 per thousand live births, with 1.5 to 3 per thousand live births in term neonates, and it's very high in preterm neonates. So 10 to 130 per 1,000 live birth. So this is, a real problem. And in preterms, it is also difficult to identify or tease apart between what is epileptic and what is non-epileptic. So I'm using the term epileptic and non-epileptic repeatedly. So epileptic means something where there is an enduring preposition of the brain to generate seizures, and by its neurophysiologic effects, its psychological effects, its cognitive effects, and the other issues. Okay. अब ये enduring preposition कि भाई ब्रेन में सीजर्स आ रहे हैं या नहीं आ रहे हैं कैसे पता चले, ये बाहर से देखने का तो पता नहीं चलता. ठीक है. So the problem is कि whenever electrophysiologically, if the brain is having an abnormal hypersynchronous or excessive electrical activity, and this is either hypersynchronous means एक साथ सारी की सारी आ रही है, ठीक है, और इट इज मच एक्सेसिव देन एक्सपेक्टेड फॉर दैट पर्टिकुलर एक्टिविटी. ओके, अगर अवेक है या स्लीप है तो ब्रेन जैसा जनरेट करना चाहिए उससे बहुत एक्सेसिव है या हाइपर सिंक्रोनस है तो ये सीजर्स प्रोड्यूस करेगी, विच विल बी कॉल्ड एज एपिलेप्टिक सीजर्स. एंड वी आर ऑलवेज इंटरेस्टेड, जब भी हम बात करते हैं कि सीजर्स किसी को सीजर्स आ रहे हैं तो दीज आर द एपिलेप्टिक सीजर्स which we are more concerned about. Non-epileptic seizers, commonest example is like jitteriness. Okay, so jittery, some babies may be jittery even if they are otherwise normal, and you don't need to treat them. Okay, so whatever in this slide I'm talking about is about the epileptic seizures and not the non-epileptic seizures. Okay, so look at this. Term babies have a higher chance of having epileptic seizures as compared to older population and older children, and the preterm have much more higher. Okay, and amongst the neonates, acute symptomatic seizures are most common, which means that if the child is having some brain injury, acute brain injury, for example, hypoxic ischemic injury, or the baby is having a CNS infection, or the baby is having some viral encephalitis, then the chances of having seizures are much more common. So these are called symptomatic seizures. On the contrast, sometimes they may have an epilepsy, and these epilepsies in neonates, approximately 13% of the seizures are because of epilepsy syndromes. Okay, then amongst the epilepsy syndromes, there are two different etiologies. One is inborn errors of metabolism, and we all know the common examples being, say, for example, non-ketotic hyperglycinemia, where in the posterior brain is severely injured. The anterior is also injured later on, and it can cause severe cystic damage to the brain. And when this is there, the child has severe seizures, or sometimes this is because of a sulfite oxidase or a molybdenum cofactor deficiency, or maybe in mitochondrial disorders of respiratory chain, where the respiratory chain is abnormal. You cannot generate energy for the brain, and then you start throwing, the baby starts throwing seizures. Okay, so the incidence due to IEM is not known. The other group is channelopathies. So amongst the channelopathies, there is an example here. You can see on the right side of this slide, I've put in various mutations. So these basically cause abnormalities in the ion channels, specifically the sodium channels, the potassium channels, the calcium channels, and these channels may be either voltage gated, or they may be gated by other mechanisms. So in my pointer that the above panel in the green is normal function, where the sodium channel is perfectly doing well, and in the lower channel the protein is truncated. The protein is actually abnormal. So if there is formation of an abnormal protein, or if there is excess protein, or if there is a deficient protein, this can also cause the channel to work dysfunctional. And when this is dysfunctional, this can cause epilepsy. Okay, so incidence of neonatal seizures due to IEM and channelopathies is not very well known. The reason is very simple, because, for example, in say Karamsad, where Dr. Nimbalkar is working, he is a trained neonatologist, and he knows that he can identify genetic epilepsies much more appropriately as compared to any other person who is not that experienced. Or maybe a person like a pediatric neurologist can identify genetic epilepsies much more common. So depending upon where you're working, there may be different incidents, because some people are very confident at diagnosing these. They can suspect these earlier, and the resources which you may have. Okay, then, but still it is known that 30% of the refractory neonatal seizures are because of inborn error of metabolism, and should be chased very well. Okay, so that's about the etiology. Now coming on to what is the definition. Okay, so I'll play these two videos for you. First, the upper panel. So just look at it, and you'll realize that this child has seizures. Now, with experience, some people can say this is an epileptic seizure. Some people can think, okay, this may be non-epileptic as well. Okay, तो एक्सपीरियंस से हम इसको समझने की कोशिश करते हैं कि ये एपिलेप्टिक है या नॉन एपिलेप्टिक है. ठीक है, नाउ एज आई सेड, epileptic seizures will have an EEG correlate. So there will show that there is some problem in the brain which is electrophysiologically abnormal, because the epileptic seizures are caused by an excessive or hypersynchronous or both electrical discharges in the brain. Okay, now the problem is कि आपको ये बाहर से नहीं दिख सकता कि ये जो न्यूनेट है, जिसको अभी मैंने वीडियो प्ले किया था, इसका जो जो सीजर है, ये सीजर इसको ब्रेन में क्या हो रहा है. ओके, सिर्फ एक्सपीरियंस से हम ये बता सकते हैं. ओके, सो कि ये एपिलेप्टिक सीजर है या नहीं. ओके, दिस लुक्स लाइक एन एपिलेप्टिक सीजर, सो वी कैन से ओके दिस इज अ क्लिनिकल सीजर, बिकॉज जो ओरिजिनल वोल्पे की डेफिनेशन थी, वोल्पे वाज वन ऑफ द he was a pioneer neonatal neurologist, and he defined seizures as paroxysmal alteration in neurological function, motor behavior, and or autonomic function that occur in first 28 days after birth of a term unit or before 44 weeks of gestational age in a preterm infant. Okay, so he said कि कोई भी ऑल्ट्रेशन होता है न्यूरोलॉजिकल फंक्शन में, मोटर बिहेवियर या ऑटोनॉमिक फंक्शन, ओके, दिस कैन बी अ सीजर, राइट? बट देन द डेफिनेशन is very vague, because we realized later on that depending upon units which may be doing an electrophysiological study in neonatal seizures, the incidence changes. And जो भी लोग इलेक्ट्रोफिजियोलॉजी करते हैं उनको ये पता है कि ऑलमोस्ट 40 to 50% जो है किसी भी यूनिट में नॉन एपिलेप्टिक सीजर्स भी होते हैं. ठीक है. सो ये वाला इवेंट एक्सपीरियंस्ड फिजिशियन ये कह सकता है कि दिस मे बी एन एपिलेप्टिक सीजर. But if you put him to an EEG and you find that the EEG is normal during the seizures, then you know this is a non-epileptic seizure, right? And हम इसको फालतू में ही treat करेंगे. So now the definition has been revised by International League Against Epilepsy and is the most accepted definition. WHO also accepts this, and it says that an epileptic seizure in a neonate is a sudden abnormal electrographic event. Okay, so underline this: electrographic event characterized by a repetitive and evolving pattern of discharges. Okay, so जब भी हम इन बेबीज को जिनमें सीजर्स आ रहा है उसे ईईजी पे हुकअप करेंगे, तो ईईजी पे हुकअप करने पे अगर जो ईईजी पैटर्न है उसमें रिपीटेटिव या इवॉल्विंग फ्रीक्वेंसी चेंजेस हैं, वोल्टेज चेंजेस हैं, या उसकी मॉर्फोलॉजी में चेंज है, या लोकेशन में चेंज है, और ये मिनिमम 2 माइक्रोवोल्ट पीक टू पीक वोल्टेज, मतलब अपर भी 2 माइक्रोवोल्ट से ऊपर गया, नीचे भी 2 माइक्रोवोल्ट से ऊपर गया, और ड्यूरेशन 10 सेकंड से ज्यादा हुआ, तो दिस इज एन epileptic seizure in a neonate. Okay, so this complicates everything, because in a country like ours, not even in our country, even worldwide, globally, there is a resource limited. Not everybody is doing EEG or a continuous EEG in neonatal units, and not everyone is trained for looking at neonatal EEGs. तो ये तो बड़ी complicated बात हो गई है ना. But the problem is कि यही सही definition है. The reason is because epilepsy or an epileptic seizure entails an excessive or hypersynchronous electrical discharge in the brain causing an abnormal event, चाहे वो मोटर हो, चाहे सेंसरी हो, चाहे ऑटोनॉमिक हो. तो इसलिए सीजर की डेफिनेशन, एपिलेप्टिक सीजर की डेफिनेशन तो बिना ईईजी नहीं हो पाएगी. ठीक है. सो हाउ डू यू manage these events in our setting? So we'll discuss this in a moment. Okay, so further defining this, so if you look at this video, there is a second video here. Let me play this. So in this video you can see that the newborn is absolutely normal. Okay, अभी तक नॉर्मल है, और अब थोड़ी देर में आप देखेंगे कि इसे एक इवेंट आना शुरू हुआ, और जब इवेंट आया, नाउ ही स्टार्टेड मूविंग, एंड व्हेन द इवेंट हैज स्टार्टेड, there is a clinical event. He's having tonic posturing of both upper extremities, and there is abnormal discharges. You can see in the upper panel that there is a change in the frequency, change in the amplitude, change in the morphology of this particular EEG, and this is an electrographic seizure. So this is a true electrical or a true neonatal seizure. Okay, so further going, so I've told you that there was a definition, Volpe's definition of clinical seizure. Then there is another definition which is electroclinical seizure, or the newer definition which is the most valid definition. Okay, now how do you define the seizure burden? Okay, so whenever there is an ictal means सीजर. ओके, सो अगर ईईजी में इलेक्ट्रिकल एक्टिविटी इस तरह की हो कि वो सीजर की तरह है, तो हम कहेंगे ये इक्टल है. और जो दो सीजर्स, दो इलेक्ट्रिकल इवेंट्स जो कि सीजर हो या इक्टल, दो इक्टल इवेंट्स के बीच का जो कुछ भी होता है वो इंटर इक्टल कहलाता है. Okay, so ictal electrographic activity in a set period of EEG recording expressed as summed electrographic seizures in seconds per hour is called as seizure burden, which means अगर किसी को 1 घंटे की रिकॉर्डिंग हम कर रहे हैं EEG की, और उस 1 घंटे की रिकॉर्डिंग में अगर उसे से फॉर एग्जांपल 30 सेकेंड्स अगर एक एबनॉर्मल एक्टिविटी हुई, तो द डेफिनेशन से 10 सेकंड से ऊपर, तो अगर 30 सेकंड से, तो 30 सेकंड पर आवर इज द सीजर बर्डन. ओके, एंड दिस मे बी से 5 hours times or maybe 20 times or maybe 30 minutes se zyada. Okay, so if it is more than 30 minutes, if the electrographic seizure lasts without a clinical seizure नहीं आए कोई दिक्कत नहीं है, ठीक है, लेकिन अगर electrographic activity अगर 30 seconds से ज्यादा है, then it is called as status epilepticus. Sorry, 30 minutes से ज्यादा है, then it is called as status epilepticus. And अगर 1 घंटे के अंदर मान लीजिए 10 सीजर आए और इन सबको हमने ऐड कर लिया और ये 30 मिनट से ज्यादा है, then also this will be status epilepticus. Okay, but the definition is more than 30 minutes in a 1 hour period, which means 50% से ज्यादा time electrographic abnormality rahi hai ictal. Okay, now remember there is another problem. So I said almost every neonatal unit जो कि continuous EEG करते हैं for diagnosing neonatal seizures, more than 50% to 60% जहां हमें लगता है कि ये क्लिनिकल सीजर है, इलेक्ट्रिकल सीजर मतलब बिना ईईजी के इलेक्ट्रिकल सीजर है, वो एक्चुअली नॉन एपिलेप्टिक सीजर्स होते हैं. ओके, नाउ द अदर प्रॉब्लम इज कि कई बार क्या होता है कि जब क्लिनिकल सीजर आ रहा है, ठीक है, और आप ईईजी करते हो, तो एक चीज हो गई कि भाई क्लिनिकल सीजर है, ईईजी नॉर्मल है, तो ये नॉन एपिलेप्टिक सीजर हो गया. लेकिन ये भी देखा गया है कि जब आप ईईजी करते हो तो जरूरी नहीं है कि एवरी इक्टल इवेंट ऑन द ईईजी will be accompanied by a clinical seizure. Now that's a big problem because 50 to 60% of the electrographic seizures are not accompanied by a clinical seizure. So the problem is कि all DM residents, all residents, so PG residents who are working in neonatal units, वो उनको जो seizure लग रहा है वो actually seizure है या नहीं है, वो भी एक big question है. दूसरी प्रॉब्लम यह है कि अगर आप ईईजी कंटिन्यूस ईईजी कर रहे हो और उसे क्लिनिकल इवेंट नहीं आया लेकिन उसे इलेक्ट्रिकल सीजर आ सकता है which needs treatment, all of them need treatment. Okay, that is very important. Okay, they all need treatment. Okay, then non-epileptic events, as I said, are very common. In the right-sided panel, actually here what you see is there is an electrographic seizure which is in right central region. So this is the right central region, and it is also spreading to in the temporal region. So this is the temporal region here, if you can see my pointer. Okay, now coming on to the etiology. So the etiology, as I said, एक दो तरह से हम ले सकते हैं. एक symptomatic seizures हैं. Okay, now symptomatic seizures के commonest cause hypoxic ischemic injury to the brain, which occurs in perinatal asphyxia, intracranial hemorrhages, cerebral infarction may cause stroke. It may be because of intrauterine infections, acute bacterial infections, sometimes because of drug effect or drug withdrawal, sometimes hypoglycemic, sometimes hypocalcemic or other electrolyte disturbances. Okay, now remember, most of these symptomatic seizures, because the injury has occurred around the time of delivery or maybe in the perinatal period, they occur earlier. Okay, so day 1 to say day 7, sometimes until day 14, but mostly earlier. Most of the seizures because of channelopathies or because of inborn errors of metabolism will occur later in the life. Okay, so specifically speaking, there is something called as benign familial neonatal seizures, or currently called as self-limited neonatal epilepsies or neonatal seizures, and these typically occur on 5th day of life. The very bad seizures, और 5 दिन तक न्यूबॉर्न बिल्कुल नॉर्मल रहा, बर्थ हिस्ट्री नॉर्मल थी, नॉर्मली डिलीवर्ड, एब्सोल्युटली फाइन, 5th डे पे स्टार्ट्स थ्रोइंग बैड सीजर्स, वेरी रिफ्रैक्टरी. एंड जब आप कार्बामेजेपिन देते हैं, जिसके लिए हम हमेशा मना करते थे पहले, या लेकोसामाइड देते हैं, and they improve. The reason is they may be having a channelopathy which is because of potassium channel KCNQ2, and they respond very well to sodium channel blockers such as carbamazepine and lacosamide. तो यूं हम पहले कहते थे कि carbamazepine neonatal period infants में यूज नहीं करनी चाहिए, but nowadays we use it very frequently if this is the situation. So these newborns बाद में जाके बिल्कुल normal रहते हैं and self limiting होती है. Sometimes other inborn errors of metabolism, such as vitamin B6 responsive epilepsies, okay, so pyridoxal 5-phosphate, which is different from pyridoxine dependent epilepsies. So pyridoxal 5-phosphate pyridoxine, there may be sometimes biotin related, there may be sometimes thiamine related, or sometimes folinic acid related. Okay, तो ये सारी जो है थोड़ा सा later part में present करती है. There may be inborn errors of metabolism which may present in the intrauterine life, and these, when present in intrauterine life, such as non-ketotic hyperglycemia, so the fetus may throw seizures. Okay, so it's such that even the fetus may throw seizures. Fetus may throw seizures, and the fetus is basically, very abnormal. So the fetus is extremely abnormal. So the fetus is extremely abnormal and throws severe seizures and may be perceived as increased movements, neonatal movements. Okay, or increased fetal movements, not neonatal movements, but fetal movements. Okay, then coming on again to the classification. So finally, if you have a child who is having abnormal motor events or autonomic events or behavioral events, and you think these are seizures, they may be epileptic or non-epileptic. Okay, if now you would do a comprehensive evaluation, you'll do glucose, electrolytes, blood gas, and all the investigations and MR imaging. But nowadays, in the definition entails that you do a continuous EEG or an amplitude integrated EEG. Amplitude integrated EEG और continuous EEG में फर्क ये है कि amplitude integrated EEG is basically, we look at एक 2 से 3 घंटे की रिकॉर्डिंग को एक साथ हम एक पेज पे देखते हैं, ये देखने के लिए कि उनमें एम्पलीट्यूड्स क्या है. ओके, एंड देयर इज अ पैटर्न रिकॉग्निशन. तो हम पैटर्न्स रिकॉग्नाइज करते हैं कि अवेक में कैसा दिखता है, स्लीप में कैसा दिखता है, अगर वो सप्रेशन है तो कैसा दिखता है, लो एम्पलीट्यूड है तो कैसा दिखता है. एंड इट कन्वीनियंस इज कि एम्पलीट्यूड इंटीग्रेटेड ईईजी में यू यूज ओनली 4 इलेक्ट्रोड्स और समटाइम्स ओनली 2 मोंटाजेस. ओके, जबकि कंटिन्यूअस ईईजी में या एक फुल फ्लेजेड ईईजी में, कन्वेंशनल में, आपको सारे इलेक्ट्रोड्स लगाने पड़ेंगे. इट मे बी यूजुअली a 16 channel or a 32 channel EEG, and then you look at almost everything, every part of the brain using a 10 to 20 system of electrode placement. ठीक है, now whatever you use, चाहे amplitude integrated EEG use करो, चाहे आप continuous EEG use करो, the issue is you need expertise. Okay, so when you can identify this, तो अगर मान लीजिए जब आपने EEG लगाया, किसी को हाई रिस्क है फॉर सीजर्स या उसे क्लिनिकल सीजर्स आ रहे हैं, आपने EEG लगाया, चाहे वो एम्पलीट्यूड इंटीग्रेटेड EEG हो, चाहे कंटिन्यूअस EEG हो, कंटिन्यूअस EEG full fledged or with all electrodes and all montages is actually the gold standard. Okay, so when you do this, then you can have 3 situations. One is a non-epileptic seizure. Okay, so there may be no electrical discharges, but the child is having a lot of abnormal movements, and these are non-epileptic seizures, and you treat them differently, but you don't treat them with anti-epileptic medicines or anti-seizure medications. Or you can have abnormal electrographic discharges with the abnormal events. So motor event भी आ रहा है, या ऑटोनॉमिक इवेंट आ रहा है, या बिहेवियरल इवेंट आ रहा है, और साथ में इलेक्ट्रोग्राफिक एब्नॉर्मलिटीज आ रही है जो 2 माइक्रोवोल्ट एम्पलीट्यूड ऊपर या नीचे से ज्यादा हो और 10 सेकंड से ज्यादा हो, तो आप कहते हो दिस इज graphic seizure, not associated with. So there are EEG abnormalities, but you do not have electrographic abnormalities. Sorry, there are EEG abnormalities, but you do not have a clinical event. You say this is only electrographic seizure. Okay, and as I said, 50 to 80% of neonatal seizures are only electrographic. They are not clinical and are seen in preterm infants or infants who have hypoxic ischemic injury. Okay, so hamari problem kya hai in this country? We have preterms plenty and they have seizures plenty. We have hypoxic ischemic injury बहुत सारा नंबर है, ठीक है. और द प्रॉब्लम इज कि इनमें आपको क्लिनिकल सीजर दिखता ही नहीं है, तो आपको EEG करना ही होगा इनका, एंड यू विल हैव टू रिलाई ऑन देम. ओके, सो व्हेनेवर यू हैव इलेक्ट्रोक्लिनिकल सीजर्स, रिमेंबर there may be either a motor seizure, तो बहुत ज्यादा complicated classification नहीं है. You just say this is an electroclinical seizure. If there is a motor component, so focal, multifocal, jerking or automatism or clonic jerking, or a spasm which lasts more than 1 second, or a myoclonic which lasts only 400 milliseconds, you blink and it goes, or a tonic event, so increased tone, okay, or a sequential seizure, so there are multiple jerks or multiple behavioral abnormalities, then you say this is a motor event, okay. Non-motor is purely autonomic and or behavioral arrest, so you say it is non-motor, okay. Or sometimes agar aapko nahi samajh mein aaya, you say unclassified seizure. So for all residents, when you say there is a seizure, please classify as motor seizure or a non-motor seizure or an unclassified seizure. And we have already talked about the etiology. So that was the classification. Okay. Now the question comes, we now understand किसको सीजर कहना है, एपिलेप्टिक सीजर कहना है और किसे नहीं कहना है. ओके, नाउ द प्रॉब्लम इज कि व्हाई शुड वी ट्रीट सीजर्स इन न्यूनेट्स एग्रेसिवली एट ऑल लेवल्स ऑफ केयर. ओके, सो अगर सीजर्स किसी को प्राइमरी हेल्थ सेंटर में है या सब सेंटर में आए या वो प्रेजेंट किया सेकेंडरी हेल्थ सेंटर में और अ टर्शियरी सेंटर, at all levels the recommendation is to treat them very very aggressively. Okay, why do you do that? The problem is whenever there are neonatal seizures, there is a very high chance of mortality, so 7 to 33% mortality. The other problem is 40 to 60% of surviving neonates will have long-term sequelae, including CP, learning difficulties, or epilepsy. Makes a persuasive case to again treat them. They may have an abnormal neurodevelopmental outcome. 9 times if the seizure burden is more than 40 minutes per hour. So I said seizure burden कैसे कैलकुलेट करते हैं, 1 घंटे में आपने इलेक्ट्रोग्राफिक डिस्चार्जेस देखे और अगर ये more than 40 मिनट चलते हैं तो 9 times हमें चांसेस ज्यादा होती है एबनॉर्मल न्यूरो डेवलपमेंटल आउटकम की, which is 8 times if it is more than 30 minutes per hour. Okay, now the consensus based recommendation is treat neonatal seizures to reduce burden, which may be associated with improved outcomes, and the level of agreement is moderate. So you should treat them or at all levels. Okay, so that makes a very very strong case कि भाई कहीं पे भी neonatal seizure आ रहा है तो you treat it. Now there may be non-epileptic movements as well, as I said. Okay, so common non-epileptic movements क्या हो सकते हैं? So there can be tremors and jitteriness. Okay, so they just, what are tremors? They are high frequency, low amplitude jerky movements. Okay, when these occur or jitteriness occur, jitteriness is basically segmentally mediated myoclonus. So at spinal level, not at cortical level, sometimes at spinal level there occurs discharges, and because of these discharges there occurs myoclonus. Okay, and these are jitteriness. Okay, this is jitteriness. Okay, then there can be something called as a myoclonus. These myoclonus are also mediated at spinal level, and I'll show you an example of benign sleep myoclonus which may occur in neonates and infants and even in older children. So वो नींद में होते हैं, उनको कुछ jerks होते हैं. I'll just show you in a moment. Then there can be benign paroxysmal torticollis. So some newborns may just turn their neck on one side even during infancy, and this is actually a channelopathy, and this is very common but non-epileptic. Then there is something called as hyperklepsia, which is because of abnormality in the glycine channels, and this also causes severe abnormality. Okay, and severe. So there are two types of hyperklepsia. One is startle events, and the other is a tonic posturing. So there is a persistent tonic spasm. Okay, so they can just do a startle, or sometimes they can have a tonic posturing. Then there may be non-epileptic complex motor movements. So remember, newborn में myelination complete नहीं होता है. Even there is synaptogenesis continuing, there is networking continuing, there is pruning continuing, and because of these network नए बनते रहते हैं और ये सारा का सारा process में अगले 2-3 साल लग जाते हैं. Okay, now that is the reason कि अगर आप न्यूबॉर्न को छेड़ते हो या न्यूबॉर्न कई बार बहुत एक्टिव होते हैं तो दे हैव समथिंग कॉल्ड एज अ मास मूवमेंट. ओके, पूरा बॉडी हिलने लग जाती है, पूरा शरीर हिलने लग जाता है. ओके, सो दीज आर कॉम्प्लेक्स मोटर मूवमेंट्स व्हिच आर अगेन नॉन एपिलेप्टिक. दिस अकर बिकॉज द ब्रेन इज इमेच्योर, द माइलिनेशन इज नॉट कंप्लीट. ओके, सो दे कैन नॉट डू अ डिस्क्रीट मूवमेंट कि एक हाथ ही हिलाया या 2 हाथ ऊपर के मतलब फाइन फिंगर मूवमेंट किए. दे कैन नॉट हैपन. Then there can be subtle seizures, which are subcortical, or some brainstem release phenomena, which are basically behavioral or autonomic changes. Okay, so look at this. So this is basically बड़ा डरावना सा लगता है कि ये न्यूबॉर्न को सडन जर्क्स आ रहे हैं राइट फुट में एंड इन द राइट अपर एक्सट्रीमिटी. सो दीज आर, otherwise the child is baby is perfectly fine, and these are benign. So these are benign sleep myoclonus. Why myoclonus? Because this jerk lasts for only 400 milliseconds. You blink and it goes, और फिर दूसरा आ जाता है. और ये sequential भी हो सकते हैं और isolated भी हो सकते हैं. Sequential means coming together. Then look at the other neonate. So this neonate is having something called as a tonic spasm. तो इसको छेड़ा, हमने टैप किया ग्लेबेला पे, और टैप करते ही look at what happened. The child is having severe tonic spasm. Now this is because of an channelopathy, and simply they will outgrow of this. If you give clonazepam, they become very comfortable, and you don't need to treat them with many medication. Okay, so remember, एपिलेप्टिक सीजर्स के अलावा नॉन एपिलेप्टिक मूवमेंट्स या सीजर्स भी न्यूनेट्स में बहुत कॉमन है, और प्रीमेच्योर्स में टर्म न्यूनेट से भी ज्यादा कॉमन है, एंड यू नीड टू आइडेंटिफाई देम डिपेंडिंग अपॉन द सिचुएशन. ओके, सो द प्रॉब्लम, हमारी सबसे बड़ी समस्या क्या है? वी वर्क इन वेरियस रिसोर्स लेवल्स. सो ये रिसोर्स लेवल्स क्या हो सकते हैं? प्राइमरी हेल्थ सेंटर, कोई कंटिन्यूस ईईजी नहीं है, एम्पलीट्यूड इंटीग्रेटेड ईईजी नहीं है. वी हैव टू वर्क इन सेकेंडरी लेवल्स और टर्शरी लेवल. तो टर्शरी लेवल पे जाके कंटिन्यूस ईईजी आएगा, जहां पे भी एक ट्रेन्ड पर्सन हो. सो वी आर ऑल लेफ्ट, not even us, even in the west there are smaller NICUs जहां पे की कंटिन्यूस EEG नहीं होता है. तो हाउ डू यू से कि किसी को सीजर आ रहा है तो ये सीजर है या नहीं है? तो इसके लिए देयर इज अ वेरी गुड पब्लिकेशन इन एपिलेप्सिया पब्लिश्ड इन 2000 February 2021. You must all read this. So what they did was they said कि अगर आप, गोल्ड स्टैंडर्ड क्या है? गोल्ड स्टैंडर्ड है ईईजी से हुकअप कर दिया, अगर उसको इलेक्ट्रोग्राफिक है सीजर, तो विच मींस दिस इज अ इलेक्ट्रिकल सीजर. ओके, दिस इज डेफिनेटली एन एपिलेप्टिक सीजर. बट या एम्पलीट्यूड इंटीग्रेटेड ईईजी पे किया, और अगर उसमें इलेक्ट्रोग्राफिक एबनॉर्मलिटीज है, तो दिस मींस दिस इज एन इलेक्ट्रिकल सीजर. बट एम्पलीट्यूड इंटीग्रेटेड ईईजी चूंकि सारे ब्रेन को नहीं कवर करते हैं, लिमिटेड मोन्टाजेस होते हैं, उनकी लिमिटेशन है, सिर्फ एम्पलीट्यूड पे डिपेंड करते हैं, इसलिए ये इसका सिर्फ 60 to 70%, इवन 40 to 60% वेरियस स्टडीज में कोरिलेट है विद एन एपिलेप्टिक सीजर. ओके, सो वी आर ऑल लेफ्ट विद experience. Okay, so almost in every NICU, say 90% we don't have an continuous EEG, so or an EEG. So हम किस पे रिलाई करें? हम रिलाई करते हैं हमारे एक्सपीरियंस्ड पर्सनल पे. सो मे बी द प्रोफेसर और मे बी अ सीनियर कंसल्टेंट, अगर वो कहता है कि यार ये एपिलेप्टिक सीजर लग रहा है, तो हमें मान लेना चाहिए कि एपिलेप्टिक सीजर है. द रीजन व्हाई आई से दिस इज various studies have proved there is a level 2B evidence that if someone is saying कि ये एक फोकल क्लॉनिक या फोकल टॉनिक सीजर है, जो एक्सपीरियंस्ड आदमी है, तो ये ज्यादा चांसेस है कि ये एपिलेप्टिक सीजर ही निकलेगा. ओके, सो देयर वर स्टडीज जहां पे उन्होंने उनको ब्लाइंड किया, उनको ईईजी नहीं दिखाया, और कहा कि भाई आप ये बताइए कि ये सीजर है या नहीं है. तो उन्होंने देख के कहा, और ऑलमोस्ट 40 to 60% में दे वर राइट. ओके, अदर सीजर टाइप्स में एक्सेप्ट फॉर फोकल क्लॉनिक और फोकल टॉनिक के लिए लेवल 3 एविडेंस है. बट स्टिल दिस मेक्स अ वेरी स्ट्रॉन्ग केस कि एवरी सीजर जो कि एक्सपीरियंस्ड आदमी कह रहा है, दिस में भी द एक्सपीरियंस आदमी जो है वो न्यूनेटल नर्स भी हो सकती है, वो इज एक्सपीरियंस्ड इन एन आईसीयू, इट शुड बी कंसिडर्ड एज एन एपिलेप्टिक सीजर. ओके, इफ यू हैव अ कंटिन्यूअस ईईजी देन एक्सट्रीमली गुड. ओके, सो कमिंग ऑन टू मैनेजमेंट. सो नाउ वी नो किसको एपिलेप्टिक सीजर कहना है. अगर कंटिन्यूअस ईईजी नहीं है तो किसको कह सकते हैं एपिलेप्टिक सीजर. नॉन एपिलेप्टिक इक्विवेलेंट्स क्या होते हैं? सो एंड व्हाई शुड यू ट्रीट neonatal seizures aggressively? Okay, now let's come to the management. Okay, now each one of you know what is the management. मैं सिर्फ इसे resource perspective में डालूंगा, ठीक है? So the management is number 1, maintain normovolemia, normotension, normothermia, and normoglycemia. Okay, so each one of you, there are अभी इस audience में neonatologist भी हैं, DM neonatology students भी हैं, and very senior people. So you all know, I'm not going to discuss this, but remember, this is the most important part of triage. ज्यादातर problems इसी से ठीक हो जाएगी. Okay, whatever is the etiology, you have to manage and identify dyselectrolytemia, if there are acid-base abnormalities or infection in sepsis. You have also to identify and treat if the child is having hypoxic ischemic encephalopathy, then therapeutic hypothermia, if you have the facility, it saves a lot of morbidity and also mortality and also improves long-term outcome. And if you have experience in treating and identifying and treating inborn errors of metabolism and channelopathies, you have to use specific therapy. Okay. Now, remember, treat with anti-seizure medication. These are the guidelines. All clinically apparent seizures which are lasting for more than 3 minutes or brief serial seizures. That is for the clinical seizures where you do not have facility for continuous EEG, and all electrical seizures, both electroclinical and electrographic, without looking at the duration. अगर duration कितना भी है, उसको आपको treat करना है. That is important to improve the outcome. Okay, so in this slide I'm putting in the general principles. So number one is resuscitation. Okay, so when you resuscitate the babies, you take care of the ABC. You document and videotape any abnormal events so that they can be identified by experienced people. Okay, and if there is facilities for NICU transfer, you transfer them immediately. If you are in a peripheral setting, then transfer to a higher center. Call a neonatologist if available, pediatric neurologist, and a tech support. So tech support means उसको कंटिन्यूस ईईजी अगर चाहिएगा, आपके पास फैसिलिटी है, तो इलेक्ट्रोफिजियोलॉजिस्ट को उसको टेक्नीशियन को बुलाना पड़ेगा, इलेक्ट्रोफिजियोलॉजिस्ट को बुलाना पड़ेगा, नर्सेज जो कि इसमें एक्सपीरियंस्ड है उनको बुलाना पड़ेगा और ट्रेन करना पड़ेगा. Okay, then assess for you all vitals for maintaining normoxemia, volemia, tension, hyperthermia, hyperglycemia. Assess antenatal, perinatal and family history, and all documentation including maternal medication, physical and neurological examination. Okay, then you look at the laboratory part, so you all know what to be done. So CBC, all urea, creatinine, transaminases, serum sodium, potassium, because these are the etiology. Okay, hyponatremia can cause seizures, hypernatremia can cause seizures, calcium, so hypokalemia can cause something which looks like seizures. Okay, epileptic seizures, hypocalcemia, hypomagnesemia. Okay, acid-base abnormalities, PT-PTTK because of intracranial bleeds, blood culture for CNS infections, and you all know it. Then the advanced ones, serum magnesium, plasma ammonia, lactate, plasma pyruvate, urine, blood, and CSF for IEM workup, and genetics, depending upon what is the scope of your practice and how you are dealing, what are the resources available. Then screening head ultrasound, initially followed by MRI brain with or without contrast. Always remember, MRI is the gold standard of neuroimaging. MR spectroscopy to look at lactate peak, and it tells you more than that. Many other things a trained neuroradiologist can do. And neurocritical monitoring. So that is very important these days. Amplitude integrated EEG, continuous EEGs, or continuous video EEGs, and something called as near infrared spectroscopy to look at perfusion. Okay. So this is the broad overview. And when you identify that the child is having seizures, there can be 3 types of seizures. If you do not have facility for continuous EEG, you just say clinical seizure or epileptic movements. Or if you have continuous EEGs, then electroclinical seizures with or without the clinical event. The gold standard is phenobarbital. So phenobarbital is the drug of choice for all neonatal seizures in the doses of 20 milligram per kilogram per dose stat, 10 followed by 10 milligram per kilogram per day maintenance. Also use, if they are refractory, then phenytoin, levetiracetam, midazolam. If the child is hypocalcemic, calcium gluconate, and you all know hypomagnesemia. If hypocalcemia is associated with hypomagnesemia, then magnesium. In status epilepticus, topiramate is an excellent drug, oral topiramate, starting with 3 milligram per kilogram per day, and you can increase it to 12 milligram per kilogram per day. Some units in the West use xylocaine, lignocaine, 2 milligram per kilogram IV bolus, followed by 6 milligram per kilogram per hour, and taper by 2 milligram per kilogram per hour. And as I said, if you suspect that this is a channelopathy, use carbamazepine, lacosamide, because KCNQ2, potassium channel abnormalities, are very common in the neonatal period, and sodium channel blockers are useful drugs. Or pyridoxine, pyridoxal 5-phosphate, calcium leucovorin, thiamine and biotin, uridine and serine. These are all treatable causes. Okay. At all times, look at the left side panel of mine. Maintain normovolemia, normotension, normothermia, and normoglycemia. Manage dyselectrolytemia, acid-base abnormalities, infection, and sepsis. Identify and treat therapeutic hypothermia, specific therapies, and referral after stabilization to nearest level 2 NICU and above, and make all efforts for optimal transport. Because in this country, we know that the neonatal transport of even both normal and sick neonates is very, very problematic. So that should be ensured. Okay. So now, last part, resource management, resource-based management. So I've already discussed the broad part. So look at this. This is on the left side. You can see this is a primary healthcare facility or subcenter PHC, where you would expect there will be either an A&M or sometimes a staff nurse or sometimes an MBBS internist. Okay. So even at this place, what you can do is train them for resuscitation, documentation, and videotape. Once they identify that this is a neonatal seizure, they should immediately, draw samples for whatever they can, the facilities they have available. Minimum is blood sugar, sodium, potassium, calcium. If they have a screening head ultrasound, they can do it. Okay, monitor for normoxemia, normovolemia, normotension, normothermia, and normoglycemia, and document it well with history. Okay, they can always, because almost all these facilities have phenobarbital available, so use phenobarbital. Sometimes, if they do not respond, phenytoin, levetiracetam, midazolam, calcium gluconate, and topiramate. And I said, after stabilization, refer to level 2 or level 3 NICU and make all efforts for optimal management. That was primary healthcare center. Secondary healthcare center, just more than this. So उसमें से जो भी फैसिलिटी जो मैंने ब्रॉडली बताया जो अवेलेबल है वो अब आप करना शुरू करते हो, because this is where, this can be a CHC or a private hospital or a nursing home where an MD, a pediatric consultant, is available, or sometimes a visiting neonatologist is available, or a pediatric or an adult neurology specialist may be available. So, depending upon, अब आप अमोनिया कर सकते हो तो वो करिए, लैक्टेट कर सकते हो वो करिए, MRI ब्रेन कर सकते हो तो वो करिए, और हमेशा ये ध्यान रखिए, the gold standard is, the drug of choice is phenobarbital. Okay, but if you are suspecting, because यहाँ पे अगर 5 दिन वो न्यूनेट बिल्कुल ठीक रहा, 5वें दिन सीजर्स आ रहे हैं, अदरवाइज सब चीज नॉर्मल है, तो आपके पास अगर कंटिन्यूस EEG नहीं भी है, और आप एक ट्रायल ऑफ कार्बामेज़ेपिन यूज कर सकते हो if they not responding to phenytoin or levetiracetam or midazolam, or maybe calcium hypocalcemic नहीं है. You can also give a trial of pyridoxine, pyridoxal 5-phosphate, calcium leucovorin, thiamine, or biotin, because there's no harm in it. Okay, once you stabilize, you send them to level 3. Now, in a level 3, a tertiary healthcare facility, I don't have to speak about this because I will already talked about this. Almost every facility may be available, and now you start putting in consultant of neonatology, consultants of pediatric neurology. You have techs who may hook into continuous EEG or amplitude integrated EEG, and then you also start monitoring them, and you start treating them for almost whatever the suspicion is. You keep on ruling out something, you keep on including some diagnosis, and almost all facilities. But remember, phenobarbital still remains the drug of choice. Okay, non-epileptic movement seizures usually respond to clonazepam, most of them. Okay, and you can be liberal to identify, have a high suspicion for IEMs and channelopathies, and treat them accordingly, because if you treat them, अगर बाद में genetically prove भी हो जाए तो best है. Okay, and the investigations, of course, now you have all the facilities for the genetic diagnosis and everything. You can always order that. Okay, so that was the management. Okay, now there's something, when to suspect seizure due to channelopathy or IEM. So whenever the antenatal and perinatal history is normal, insignificant, except for, say, intrauterine IEM presentation, which happens in conditions like non-ketotic hyperglycemia and some other conditions such as serine deficiency. Onset of seizures, if occurs anytime during neonatal period and infancy, mostly in the first 2 weeks. पॉजिटिव फैमिली हिस्ट्री, ऑटोसोम, सो मोस्टली फर्स्ट 2 वीक्स, विच मींस अगर बहुत अर्ली है तो सिम्टोमेटिक ज्यादा है, और अगर उसके बाद में है फर्स्ट 2 वीक्स में, फर्स्ट वीक के एंड पे या बाद में, तो आईएम या चैनलोपैथी ज्यादा है. Then positive family history, autosomal dominant, de novo in channelopathy, or autosomal recessive and maternal, for example, mitochondrial in IEM. If the brain alone is involved, chala chances hai channelopathy hai. If multiple organs are involved, then IEM. MRI at seizure onset may be normal in both IEM and channelopathies, but may show brain atrophy in both channelopathies and IEM subsequently, and sometimes specific abnormalities related to IEM. Okay. And EEG may show a normal or a burst suppression pattern. What is a burst suppression pattern? Very simple. हमेशा ध्यान रखिए कि ईईजी जो है एक अच्छा एक्सपीरियंस रीडर पैटर्न रिकॉग्निशन पे चलता है, तो वो बता सकता है कि ये अवेक है, स्लीप है, क्वाइट स्लीप है, एक्टिव स्लीप है, ठीक है. और बर्स्ट सप्रेशन क्या है? इफ दी एवरीथिंग इज सप्रेस्ड और बीच बीच में थोड़े से बर्स्ट आ रहे हैं, दिस इज अ बैड ईईजी, कैरीज अ बैड प्रोग्नोसिस एंड मे बी सीन इन सीवियर हाइपोक्सिक इस्केमिक इंजरी और इन चिल्ड्रन हु मे हैव सीवियर आईईएम्स. ओके, नाउ the question always remains, when do you discontinue ASM, anti-seizure medications? You have treated them, okay, now when do you discontinue? So the consensus now is, number one, you stop them whenever there is there is cessation of acute provoked seizure. So electroclinical या electrographic दोनों ही seizures रुक जाए तो आप बंद कर दीजिए, और एल्स अगर मान लीजिए आपने देखा कि क्लिनिकली सीजर नहीं आ रहे हैं, द चाइल्ड इज इंप्रूविंग क्लिनिकली, सो एट डिस्चार्ज यू कैन स्टॉप एंटी सीजर मेडिकेशन. द रीजन फॉर दिस इज दैट इन वेरियस स्टडीज इट हैज बीन प्रूव्ड दैट देयर इज नो सिग्निफिकेंट रिस्क ऑफ सीजर रिकरेंस बाय एज 12 months. नो सिग्निफिकेंट, व्हिच मींस हो तो सकते हैं पर इतनी सिग्निफिकेंट नहीं है. Secondly, there is no difference in developmental outcomes at 12-month follow-up, which was adjusted for brain MRI abnormality. तो कितना भी brain MRI abnormality और severity और number of seizure days during admission, तो उसको जब adjust किया तो ये कहा कि developmental outcomes में कोई फर्क नहीं पड़ता अगर आप उस समय discharge भी कर सकते हो. Okay, so thank you so much. I think I believe it was overwhelming, but I tried to simplify this. And thank you again, Dr. Nimbalkar, NNF India, NNF Gujarat, and almost all stakeholders. Thank you so much for having me here. I'm sorry I overshooted the time, but then thank you. Thank you for having me.
Thank you very much, sir. I'll just hand over to Kunal for discussions and questions.
Thank you so much, sir. I think a neurologist knows the brain very well. So the way you had explained it, it has directly gone to our brains. Never heard a lecture so simplistic and at least entering my brain, I would say. Thank you so much, sir, for the lucid talk you had given me. I have few questions also, but if anyone from the audience wants to directly ask the questions, they can unmute themselves or post in the chat also. Uh, sir,
Uh,
yes, please.
hello, sir. My name is Vishal. Actually, I'm from Ahmedabad, Urban Newborn Care Center, one of the consultants over there. So my question would be that we know that most of time, we treat the epilepsy, but sometimes we are worried about the side effect of the phenobarbital. So what's your take on the preterm babies if you overtreat, or either few of the center also using as a sedation? So, is there any message from your side that can we, because we have a lots of facility, like we can use the fentanyl or something else, but sometime, for example, meconium baby or sometime preterm baby, people used to take as a sedation. So can we use that one? Does it affect the long term outcome, or anything further?
Okay. So the question for everyone is, for everyone's interest is, कि phenobarbital के long-term problems क्या है? So I think let's take it from there. Okay. So from my talk, you would appreciate that अगर neonatal seizures, apart from neonatal epilepsies, if there is a neonatal epilepsy, a channelopathy, you will require the anti-seizure medication for a long time. And when you require these anti-seizure medications, say for 6 months or 1 year or 2 years, it's mostly dependent upon what channelopathy you are seeing. ओके, सो फॉर एग्जाम्पल आई सेड कि शुरू में पोटेशियम चैनल से ज्यादा रिलेटेड होती है, और अगर मान लीजिए 3 मंथ 4 मंथ पे डीपीटी वैक्सीन लगाया और फिर सीजर्स आ रहे हैं, माइक्लोनिक सीजर्स हैं, ड्रेविड फिनोटाइप है, तो वो चांसेस ज्यादा है कि सोडियम चैनल से रिलेटेड है। ठीक है, तो मैं क्या करूंगा, अगर मैंने एपिलेप्सी आइडेंटिफाई करी नियोनेटल पीरियड में और मैंने कहा कि ये सेल्फ लिमिटेड नियोनेटल एपिलेप्सी हो सकती है, तो और वो सोडियम चैनल ब्लॉकर्स को रिस्पॉन्ड किया, तो आई यूज देम, देयर इज नो क्वेश्चन ऑफ फिनोबार्बिटॉल, राइट। अगर सिम्टोमेटिक सीजर्स हैं, तो आई सेड द कंसेंसस इज टू स्टॉप इट देयर एंड देन। ठीक है, तो यूजुअली यू विल नाउ इन दिस एरा नॉट एनकाउंटर अ सिचुएशन जहां फिनोबार्बिटॉन बहुत लंबी देनी है। ठीक है, लेकिन अगर देनी पड़े तो व्हाट आर द प्रॉब्लम्स? द प्रॉब्लम इज it has been amply proved कि phenobarbital can cause problems with behavior. It actually, you know, there are some problems in synaptogenesis as well, in pruning, and you know, a lot of other networking in the brain which are related to phenobarbital. But remember, this has also been observed with levetiracetam. People have proved this with levetiracetam as well. So now we say, okay, आपको अगर एक्यूट सिम्टोमेटिक सीजर के लिए फिनोबार्बिटॉन देना है तो दे दीजिए, वो गोल्ड, वो बेहतरीन ड्रग है, बेस्ट एक्सपीरियंस है। लेकिन अगर लंबे समय तक देनी है तो रिवाइज द डायग्नोसिस, व्हिच मींस यू आर डीलिंग विद एन एपिलेप्सी। ओके, अब ये अगर सिम्टोमेटिक एपिलेप्सी है, स्ट्रक्चरल डैमेज की वजह से है, ठीक है, यू कैन ऑलवेज यूज लेवेट्रासेटाम और अदर ड्रग्स। ओके, बट डेफिनेटली फिनोबार्बिटॉन फॉर लॉन्गर पीरियड्स is known to cause problem. Even levetiracetam can cause this. We do not have much experience with it. Okay, so the crux is use any anti-seizure medication which is the most appropriate in that setting and for the shortest duration possible. Okay, fine. Phenobarbital definitely longer terms may it can cause problems. So that's my take.
Even sir, there is no difference between term versus preterm. Am I right?
Pardon me?
Sir, even there is no any difference of the like a preterm and term, you know, side
Yes,
effect. Like
yes,
if you use
yeah.
both have
So,
a same long term effect. Okay,
yeah.
thank you,
So,
sir.
so you know, if we Google and look at the studies of phenobarbital used in premature neonates, बहुत कम है. There, you know, I whenever I face this question, I go back to look at the publications, and I do not find phenobarbital preterms में सिर्फ 5 या 7 top class articles हैं. And most of these have also been long term में, because you know it's difficult to tease apart कि what is happening due to what is the developmental issues related to prematurity itself versus phenobarbital. ये बड़ा मुश्किल है, कोई नहीं जान समझ पाया है कि 10 साल बाद प्रीमेच्योरिटी ज्यादा प्रॉब्लमेटिक थी डेवलपमेंट के लिए या फिनोबार्बिटॉन थी. सो दैट्स द इश्यू. बट सो आई डू नॉट हैव एन आंसर टू दैट कि प्री टर्म ब्रेन में ज्यादा प्रॉब्लम क्रिएट करेगा या टर्म ब्रेन में, बट देन दैट्स हाउ इट गोस.
Sir, there is one question. Which oral anti-epileptic medicine on discharge if needed? So if the child is having suppose symptomatic seizures are there and the child needs an anti-epileptic drug, which would be preferred? Phenobarbital, levetiracetam or any other drug, sir?
Okay, so the consensus is if you have a symptomatic seizures, or maybe if the child had refractory seizures during the NICU admission, and when you send them home, if there are, if they see, you look at the clinical picture, you look at the EEG, okay, अगर अभी भी उसे सीजर्स आ रहे हैं और आपको डिस्चार्ज करना ही पड़ रहा है, तो the child can go on home on phenobarbital, and 3 months बाद में आप दोबारा से EEG कर लीजिए. Some people will do it at 1 month, some people at 3 months. So there's no consensus on that. ठीक है, but still what we practice is usually 3 months पे हम दोबारा करते हैं और क्लिनिकली देख लेते हैं. अगर baby is not having any seizures, if the EEG is not showing something sinister, we would stop phenobarbital. Okay, some people are very comfortable with levetiracetam, so I also use levetiracetam very frequently, and now brivaracetam, but you know the experience is limited. We still do not know कि क्या होता है. Now the problem is almost 30 to 40% of babies who have a severe neonatal injury, for example, because of HIE or because of, say, intracranial bleeds, will land up into epileptic spasms later on, which is a different type of epilepsy, or epilepsy with myoclonic epilepsy in infancy, myoclonic seizures in infancy, what is called as EMEI. These are epileptic encephalopathies. When you have an epileptic encephalopathy, you have to treat them differently. ओके तो तब फिनोबार्बिटॉन की जगह वाइगाबैट्रिन और स्टीरॉइड्स आ जाएंगे, या स्टीरॉइड्स अलोन आ जाएंगे along with, to break that cycle, and then other drugs may be used such as topiramate, or depending upon how you do it. So these are all hypothetical situations कि जब वो डिस्चार्ज होगा तो क्या करेंगे. अगर so this was about symptomatic seizures. अगर मान लीजिए चैनलोपैथी है तो of course the child goes back home on carbamazepine or lacosamide, right? If the child was having an inborn error of metabolism, say pyridoxine dependent seizures or pyridoxal phosphate dependent seizers, वो फिर एक डिफरेंट सिचुएशन हो जाएगी, फिर वो उस पर गड़ जाएगा. ठीक है. नाउ देयर इज so it all depends on what is the situation exactly. Now let me quote Dr. KP Vinian here. So Dr. Vinian is down south in Kerala. He's a pediatric neurologist, and his work mostly focuses on channelopathies, and he has published a lot of beautiful articles, beautiful, wonderful publications, and he has given us the phenotype. तो किस समय सीजर ऑनसेट होगा, किस तरह के सीजर्स आएंगे, ठीक है, और तब आप क्या चैनलोपैथी सस्पेक्ट करेंगे, आप क्या सिचुएशन सस्पेक्ट करेंगे, राइट? पाइरिडॉक्सिन डिपेंडेंट में कैसे आएगा. सो ब्यूटिफुल पब्लिकेशन, एंड विद माय ओन एक्सपीरियंस, सो आई हैव ऑलमोस्ट अ डेटाबेस ऑफ around 350, more than 3000 patients who are genetically proved with epilepsy. Okay, इनमें से almost आप देखिए कि 20 to 25% are those who are having neonatal onset. ठीक है. And now in these, the experience we have also built up is, so we have not published that, but we can now do a pattern recognition. We can phenotypically हम आपको ये बता सकते हैं neonatal period में कि इस तरह के सीजर्स आ रहे हैं, ये इलेक्ट्रोग्राफिक पैटर्न है, तो दिस कैन बी द प्रोबेबल इटियोलॉजी. Okay, so if you are interested, I think you should all read KP Vinian, and Vinian is a fantastic, मैं डॉक्टर निम्बालकर से रिक्वेस्ट करूंगा कि अगर कभी पॉसिबल हो तो you can have Dr. Vinian for this particular aspect. So he's fantastic. He's like pattern recognition में, because he has built up that experience. Okay, so treatment choice will depend on what is the etiology of these seizures, जो कि आप डिस्चार्ज तक almost 20 to 30% babies में you will note the etiology. 20 to 30% में से genetic diagnosis के बाद और retrospectively, and 20 to 30% में कभी भी पता नहीं चलता कि क्या etiology थी. Okay, so that's how, in our experience it goes. So the treatment depends on the etiology basically.
Okay, sir. Sir, one more question is, some of the neurologists say that you can give prophylactic topiramate as neuroprotective agent for the babies who have had HI. So, as per your experience, do you have any role of this topiramate?
So there have been many agents, including erythropoietin, topiramate, and many more agents which have been used now, for neuroprotection apart from therapeutic hypothermia. So topiramate is a toxic drug. I must tell you, use it only if needed. Recently, पहले इसके side effects में sedation, loss of appetite, behavioral disturbances. There was increased chances of renal stones, renal calculus. ठीक है, ये सब बहुत common थे. Now we know it's a teratogenic drug, so it is now not to be used during pregnancy. Okay, remember the brain, neonatal brain is a developing brain, और 2 साल तक बहुत सारी चीजें होती है ब्रेन में, right? So we do not have sufficient experience with topiramate, except for बहुत मजबूरी हो, बहुत रिफ्रैक्टरी हो, स्टेटस हो जो किसी चीज को रिस्पॉन्ड नहीं कर रहा है, give a trial of topiramate, but don't use it for, if it is not needed. Okay? Because frankly speaking, आपने कहा कि मतलब क्या होगा उससे, I also do not know. आप publication देख लीजिए, मैं रोज मतलब every month, there are many publications, and we usually try and filter these publications from our own interest. तो जब topiramate की teratogenicity discover हुई, we realized that it's a very toxic drug, and the same speaks with zonisamide as well, the same mechanism. And I would not recommend it. I would not say कि topiramate को neuroprotective use के लिए करिए जब तक कि you sufficient experience is not built up and it comes as a recommendation, a class 1 recommendation with level of evidence, strong level of evidence.
Okay, thank you, sir. There are few more questions, but because of the interest of time, we will be stopping here. Again, thank you so much, sir, for the wonderful session. It was really very easy for us or everyone to understand the your topic, and we would like to have you once more or many times more also in the near future also. So I request you, sir, please accept our invitation. For the after few months also we'll invite you for another talk, sir.
I must express my gratitude. See, I find Dr. Nimbalkar is a fantastic person, और उन्होंने I've been, मेरे मित्र हैं और हम कई फोरा पे साथ में रहे हैं, हम एग्जाम भी साथ में कंडक्ट किया है, and he's the right person, president elect NNF, and अभी हम recently we are working on a neonatal neurocritical care module. Okay, this will be free, and our partner हमारे एक बहुत अच्छे मित्र हैं डॉक्टर निम्बालकर और हमारे डॉक्टर नितिन चौथाई, and his there are other people as well. So we are trying to put that module that will be, we will try कि वो बिना कॉस्ट के हो और उसमें हम ये सब चीजें ले. So we are drafting that module. So I really feel grateful to Dr. Nimbalkar, Gujarat NNF, for having me here. मैं बहुत I do not know whether I shared, मुझे बहुत सिंपल तरीके से मैंने कोशिश किया, ठीक है, और ये सबको मालूम है, everybody knows this, right, पर फिर भी just to put it in perspective. So I think, और डॉक्टर निम्बालकर जहां जहां कहेंगे वहां हम साथ में बोलेंगे, और भी बहुत सारे लोग हैं जो एक्सपर्ट्स हैं, एंड we appreciate them. So मुझे सुनना भी है, मुझे डॉक्टर निम्बालकर का पर्सपेक्टिव सुनना है on neonatal care. So my interest is neonatal neurology and pediatric stroke. So I think I'm keen to hear from Dr. Nimbalkar his talks, and also other people from Gujarat NNF. So मुझे आप ज्वाइन करने दीजिएगा, जब भी हो मुझे अपॉर्चुनिटी दीजिएगा कि मैं एज एन ऑडियंस आपके साथ में हूँ. थैंक यू सो मच.
Thank you very much, sir. Thanks a lot. Thanks a lot.
Thank you so much, sir.
Thank you.
So yeah, thank you, sir. Thank you, Somsekhar sir, for joining and guiding us through this session. Is our advisor for Gujarat State NNF. I thank you all the delegates for joining, and thank you ClearNet for the seamless experience. Rituparna, are you there?
Yes, sir.
Yeah.
Thank you once again for generously contributing your time and effort today. And thank you for extending us the opportunity to host the session. Looking forward to host you again soon in another interactive session in the near future, sir. Till then, stay safe and healthy and have a nice day. Goodbye to all.
Thank you.
Rituparna, would this be on YouTube?
Yes, yes.
Yes,
Okay,
sir.
great.
We'll send you the link, sir.
We'll
Okay,
send you the
thank you so
link.
much. Thank you. Thank you so
Thank
much.
you so much, everyone.
Bye.
Goodbye. Take care.
Thank you.